the bone. See, non-pneumatized. This entire bone chuck, if we remove, we can uncover the entire skull base in no time.
So please tell the other landmarks for the carotid. You told us the one landmark, the eustachian tube for the pharyngeal part.
Okay.
What are the other?
For different segment, different landmark. Number one, for parapharyngeal, the eustachian tube is one of the best landmark. Another is V3. This V3, where it comes out of the, middle cranial fossa, it comes like a horseshoe leg crossing the horizontal petrous carotid into the infratemporal fossa. This V3 runs in the floor of the middle cranial fossa, crossing the horizontal petrous carotid and runs down like a leg down, horse leg, in the infratemporal fossa. So in infratemporal fossa, where it comes down, the carotid is 4 to 5 millimeter behind.
Okay.
So it is one of the good landmark for the parapharyngeal, upper parapharyngeal carotid also. Now, from that, it enters the petrous canal into the temporal bone. In temporal bone, there is vertical course, Jain and horizontal course. And the best landmark for that is the eustachian tube and the cochlea.
Okay.
Cochlea is just behind the Jain of the carotid, and eustachian tube is just lateral to the carotid. So when you work in the middle ear, don't go medial to the eustachian tube blindly to injure the carotid. Carotid and cochlea are having some millimetric distance sometimes decent even. I will show you this part of the carotid, the vertical and horizontal course once we dissect the just after this in the second half the temporal bone. So that is the petrous part of the carotid. Then it runs horizontally in the middle cranial fossa floor to come to the foramen lacerum. For foramen lacerum, again eustachian tube is a good landmark, as you need not to go above the level of the eustachian tube where the carotid is, where it comes out of the foramen lacerum. But the best landmark is the median now.
Okay.
Median is amazing. Then for the cavernous carotid, we have median and lateral OCRs. Median and lateral opticocarotid recesses are the landmark where you can find the carotid so easily.
Sir, how much behind median now you should expect this carotid?
It's
Much
not
is
about the behind. See, this
drilling is permitted for median.
median nerve is formed at the foramen lacerum. It is formed at the level of the foramen lacerum, and crossing the carotid angle, it comes down anteriorly. Angle means where the horizontal petrous carotid becomes the cavernous carotid. This comes out at that angle. So if you follow the carotid, you follow the median, infero-medially drilling the median canal, it will take you directly to the foramen lacerum. This is one of the best landmarks to find the carotid at the foramen lacerum. Here, if we try to, I can show you, the issue is, this is too thick a bone, which needs drilling. This is not pneumatized. So I need to follow this median canal. There's the median nerve here. There's median nerve here, median canal. So thick bone, almost 3 centimeters. To go right there, see that's a carotid, right there behind at the foramen lacerum, there. So this is not a pneumatized one. So you need to drill away this thick bone. You can see this cavity, that is infratemporal fossa. I hope it is very clear.
Yes, sir. Very, very clear. Crystal clear.
Infratemporal fossa, that is nasopharynx. This is your pterygoid process ending just before the eustachian tube. From the posterior edge of the pterygoid plate, the carotid, parapharyngeal carotid is 2 centimeters behind or more than that. I can remove this entire chunk. See this pterygoid bone to see the eustachian tube right from here till running high up to become the bony eustachian tube. So the entire eustachian tube can be seen, and in that situation, eustachian tube is one of the best landmarks to protect carotids. Even in nasopharyngeal malignancies, post-RT or non-RT sensitive malignancies, nasopharyngectomy is one of the standard way, and then everything revolves around the carotid artery, because you have to resect the lesion anterior to the carotid, and your one and only guide is the eustachian tube.
Yes.
So eustachian tube is an amazing landmark for the carotid artery for that region. Anything before we?
No, sir, thank you so much. Maza aa gaya, sir. A grand opening to the conference, as always. and we are enlightened. Thank you so much.
Very interesting session coming up
Sir,
after this.
So just a
Before-
small query. Hello, sir.
Yes,
Sir,
hello?
hello, sir, just a small query I want to ask.
Yes, please, please.
Sir, what can be done to prevent Seneca formation in case of endo-DCR surgeries, sir? Endoscopic DCR surgeries.
For any surgery, synechia are formed when you have opposing raw surfaces left.
Right, sir.
So your, tissue handling is important to avoid making raw surfaces on either side wherever working. So
Sir,
the
in case
tissue
of
handling,
a narrow cavity with a high deviation in the
you
septum,
correct the high deviation first at the same time.
but sir, won't that lead to difficulty in exploration of the lacrimal system?
No,
Won't-
it will make your life easy. If you
Oh,
correct the high deviation, it will make it easier.
Right, sir.
So before we start the temporal bone and the lateral skull base, we have a very interesting session coming up from our own Dr. Dharamveer Sethi, who is going to speak on a very, very innovative, work he has done, correlating the anatomy and radiology of the temporal bone.
Oh,
We know he is a world leader, popular as an endoscopic surgeon,
This is
who
Haryana.
introduced and popularized endoscopic surgery in our country almost 2 decades back by number of workshops, and is one of the most popular name in this region for the endoscopic surgery. And he has been our teacher. He's a accomplished person, not only having interest in endoscopic, but nowadays more and more working on some innovative work on the temporal bone, particularly on anatomy and radiology. So he's going to speak, say for 45 minutes or so, on a very interesting subject. And after that, we'll follow those tips in our next dissection. After that, the temporal bone. We all know radiology is like a Google map for the surgeon. With radiology, you can map out relationship, 3-dimensional relationship of all critical structures. You can measure the structures from each other by millimetric or sub-millimetric distance, and which can help, a lot during the surgical course. So that is going to be the part of the, program today. Any question before we move on?
Thank you, Satish boss. It was a wonderful demonstration, and we wish we had more time with this skull base dissection, so that we could have seen the eustachian tube part and the more of the middle cranial fossa part. There is one question from the
Yes.
The one question is that in one of my patients, I was in a patient of Jain. I happened to injure the V2. Hello.
I happen to injure the V2.
Yeah.
Okay.
But the patient did not have any complaints as such. So is it normal that the patient will have some clinical complaints if the V2 is injured?
See, V2 is an important sensory nerve, and it definitely leaves deficit, sensory deficit.
Okay. Thank you, sir, for a wonderful demonstration. We all were enriched by your wonderful dissection.
Thank you, sir, once again.
No, that's why I just announced. That's why I just announced. Yes, yeah, I didn't see, but I. Hello? Hello? Hello?
Hello.
Yeah, so we were discussing about the V2 injury. Hello?
Just a minute.
Yes, sir. We were just asking about injury to the V2.
Yeah, so injury to the V2 always reflects. Now, if it goes unnoticed to the someone who is least bothered is a different aspect, but it is a sensory nerve and it definitely gives, hyposthesia on the part of the face and the upper alveolus.
Sir, basically Dr. Sethi sir is joined. He can't
Yes, sir.
unmute now. He can unmute himself and talk, sir.
So I'm handing over the, now the mic to Dr. Sanjay Khanna. Dr. Khanna.
Hello. Yes, please.
Yes, so over to you to invite Dr. Sethi and further proceedings.
On kar do usko. Just a minute. We are having live pictures from Singapore. Hello, Dr. Sethi. Good afternoon.
Hello, good afternoon. How's everyone?
This is Dr. Sanjay Khanna from Karnal.
Hello, Dr. Khanna. How are you?
I'm fine, thank you. And how are you, sir?
I'm fine, very well. And
Good,
thank you so
good to
much
see
for
you.
giving me the opportunity to talk today. What am I supposed to do now? I just share my screen or?
Yeah, you can, sir.
Okay, so you can hear me well? Everything is okay?
Definitely. Very
Okay,
crystal
great.
clear picture. Very
Okay,
beautiful
great.
picture. Very handsome
Okay.
guy over there.
Oh. You must be kidding.
And we
Okay,
are
let me
having
see.
this live telecast all over India and internationally also. And we are having your slides also. So welcome, Dr. Sethi. This is from Society of ENT Surgeon based at Karnal.
Mhm.
And we are having so many people over here in the audience. And also it is going live.
Yeah, so tell me, can you see my slides?
Yeah, we can see.
Okay, great. So shall I start then?
Yeah, please carry on.
Okay, great. Thank you very much, Dr. Khanna and the entire organizing committee for Explore ENT 2022 Karnal for giving me this opportunity to speak today. And specifically, I also want to thank Satish, who I've known for almost 20 years now, and for giving me also this platform to talk a little bit about temporal bone anatomy. First of all, some disclaimers. I have no conflicts, and as you all know, I'm not a ripologist. So what I'm presenting today is very basic and is meant for residents and maybe postgraduate students, and definitely not for the experienced surgeons. And so if there are any experienced surgeons there and otologists there, they might be bored. So please, viewer discretion is advised. I would like to pay a tribute.
Just interrupting, sir.
Yes.
Sir, we are still learner and you are guru of gurus.
So, where Satish is my guru now.
You are
कहते हैं ना, कभी होता है जो गुरु होता है ना वो चेला बन जाता है. So I am his chela now.
Sir, ये भी एक credibility है, sir.
Yeah, it's a cycle of life. It's a cycle of life. Okay. So I'd like to basically acknowledge Professor Albert Roton, who I've known for several years, and I've met him several times in the US for skull-based meetings, for American Academy meetings. Incredible person, always very, very amazing, excellent speaker, towering figure, and his knowledge for the anatomy, unbelievable. So been a pleasure meeting him through my journey of life. And what I'm going to present today is some of his slides. So this basically, I would like to acknowledge him. Professor Roton passed away about 6 years ago, 2016. So this is my tribute to him. So the part one of this temporal bone anatomy or course will be on just to refresh your memory on some of the salient features or pertinent features of temporal bone anatomy that are relevant to radiological anatomy. What I'm going to talk about is mainly radiological anatomy. Before I go on there, I'll spend about 15 minutes on refreshing rather my memory, or maybe somewhat yours also, on the temporal bone anatomy. So basically, I think as you can see here, the temporal bone is has a basically has sutures, sharing sutures with the greater ring of the sphenoid. We talked about that just now when Satish was demonstrating the medial cranial fossa. This is the zygomatico temporal suture, where the zygoma, the zygomatic, the process of the squamous temporal bone fuses with the zygoma. And here you see the tympanosquamous suture, and this is the tympanomastoid suture, and here behind you see the ospitomastoid sutures. The reason I talk about these sutures is that I think Satish, I remember one of his talks, he mentioned that there are at least 34 sutures in the temporal bone. And if we can just remember about 7 or 8 of them, that's good enough already, because these sutures sometimes can be very confusing. And if someone who's not familiar with them, maybe may confuse them with fractures of in the temporal bone. Now, internally, when you go inside, you can see this is the squamous suture, which runs right from the skull base up down to the curion right here. And this suture is between the greater ring of the sphenoid and the squamous part of the temporal bone. We also see the foramen ovale that Satish was alluding to just now, and the foramen spinosum right here. And the other suture we talk about is the sphenopetrosal suture, which is also between the greater ring of the sphenoid and the petrous part of the temporal bone. And this is closely related to the eustachian tube and the levator-palatini muscle. We'll talk about that a little later. The body of the sphenoid forms basically a synchondrosis with the basilar part of the occiput bone to form the clivus. This is not really a suture line, but it is the synchondrosis. And then the petrous part of the sphenoid fuses with the so strictly speaking, these can be called sutures, or you call them fissures, because there's sometimes a gap between the two. So you can call it a fissure as well with the occipital part, and this is called the petro-occipital suture. And when you go behind, you see here the suture line between the occipital bone and the mastoid, that is called the occipitomastoid suture. Now, at the apex of the petrous part of the temporal bone runs the carotid artery. We heard that just now from Satish very eloquently. And do you know what this is? Anyone can tell me what is this foramen right here? Well, if you think that this is the foramen ovale, foramen spinosum, you're wrong, because that's right here. So this is the posterior opening of the of the Vidian canal, pterygopalatine canal, and the other structure that you see here is the lingula. Now, the lingula actually has a ligament that attaches from the petrous part to the sphenoid part, and that is called the petrolingual ligament, which is a landmark, very important landmark for the surgeons, because that is where the petrous part of the internal carotid artery ends and the cavernous part begins, the petrolingual ligament. I think somebody was asked that question just now to Dr. Jain. Now, the petrous part of the temporal bone has an anterior surface, which is shared with the middle cranial fossa. It has a posterior surface, which shares with the posterior cranial fossa. We're talking about that later. And it has an inferior surface, as you see here, which we'll be talking about. And we discussed Satish discussed some parts of it earlier in the dissection today, and we'll talk about that a little later. So coming down to the temporal bone, this is the squamous part of the temporal bone. This is zygomatic process, tympanic plate, tympano-squamous suture, tympanomastoid suture, the mastoid process, and medially you will see the petrous part of the temporal bone. So this bone was actually presented to me by one of the consultants when I was doing my fellowship in 1987 in Glasgow Royal Infirmary, which was very strong in otology at that, and it still is. I did my FRCS from there, and he presented me this bone, and it has remained with me till today. The year was, I think, 86, 87, and till today I have this bone, which is a beautiful demonstration of the anatomy as relevant to the CT scans, and I'm going to discuss that today. So if you look at it, the inner surface of this temporal bone, you see this is the squamous part, and the middle meningeal artery, which is the frontal branch of the middle meningeal artery, which runs as far as up as the pterion. And sometimes there is any injury to the pterion, you can get injury to this branch of the middle meningeal artery, and you can get an epidural here. But what is more interesting from the radiological point of view here is that look at this here. This is the tegmen. Note that the tegmen is higher than the arcuate eminence. And it is because of that, when you're looking at the axial films of the CT scan of the temporal bone, you'll come across the mastoid hair cells first before you start looking at before you start seeing the superior semicircular canal. You see beautifully the superior semicircular canal here, the green shadowed in green.